Good afternoon, everyone, and welcome to the 8th session of our UNC Health COVID-19 Game Changers series. We're delighted that you can be with us today. My name is Leslie Nelson Bernier, and I have the privilege of serving as president of the UNC Health Foundation. And again, it's just a real pleasure to welcome you. I know many of you have been with us for our previous sessions, and you're in for another real treat today. I want to just encourage you again, like you saw on the guidance, to please use the question and answer feature on your Zoom to ask questions of our panelists. You're also able to, while you can't share your video or your screen, you can chat. So use those two features throughout the course of our time together today. We really do hope that it will be interactive. Now, it is my pleasure to start us off with introducing Dr. Wesley Burks, who serves as our Dean of the UNC School of Medicine and CEO of UNC Health. Dr. Burks?
So Leslie, thank you, and thank the rest of you for joining us today. I'm excited to be joined by our panelists, Amy and Amir and Dirk, that will be introduced in a few minutes as we get started. Amy and Amir have done some truly game-changing work here in the field of COVID-19 testing over the last couple of months. It's pretty remarkable, and you'll find it fascinating what they've done so quickly. And Dirk, who many of you heard from back in May in one of our game changer sessions, continues a lot of his truly game-changing work in the field of virology around the coronaviruses. Each of them in their own way are helping us to manage and adapt to life in the pandemic and hopefully learn from it, and then hopefully relatively soon, whenever that might be past the COVID pandemic. As we started each session, what I wanted to do is just try to give you an update where we are from a system on our mission, which is to provide the highest quality healthcare for patients that have COVID and then care for each other. From a treatment, big picture, testing standpoint, a vaccination standpoint. Since mid-December, when we started giving the vaccines here in Chapel Hill, Raleigh, and all across the state, we've given over 210,000 vaccinations now, which is pretty remarkable. We've been able to add in the last week the Johnson & Johnson vaccine, which has helped us reach different populations in different ways. I've talked a little bit about it before, but the first time that we had a person here in Chapel Hill that got vaccinated in mid-December, I walked over, not anticipating the emotions that were there. And you may think, well, you should have thought about that, but we walked over and thought this will be good and interesting. And as the different people were talking, then like this frog jumped in my throat, and I'm going like, and it just, I think it hit all of us that it's a pretty momentous time, that how much work had been done that rapidly. And then you fast forward 2 months and I was able to walk into the same room and get the same vaccine. So it's been a remarkable process the last couple of months for the vaccines. All across the state, we have our coworkers at 17 of our sites at a mobile health van. Those that are going into communities that have been underserved to try to help people, give them the opportunity to get vaccinated. I went down to visit our group that had the mobile clinic at Kinley a couple of weeks ago, and they were about 10 of our colleagues were in a small rural church giving vaccinations to people in the community. And just to listen to their story, to watch the people in the community walk in and their excitement and their trepidation, but their relief once they got it, it was pretty amazing. And it will be a lifelong memory for me. I know you'll hear more about some of the variants and what we anticipate will happen in the next few months as we talk more today. Last week, we had a milestone, like all of us on the Zoom. We had our 1-year anniversary of the first COVID patient in North Carolina, and we took various times and venues to just reflect on what the year, and when I say year, at times it seems like a couple of weeks, and at times it seems like a decade. And I know each of the colleagues that are on the Zoom with us today can describe some of those same emotions. I have so many personal memories and lessons that I learned that I hope that I'll continue to have for a long time. And I know each of them do, and they'll share some of that today. So as we get started, what we've done each time is just to kind of meddle in them, ask them a personal question, So we've passed the 1-year mark, and how's your life and work changed since last March? So I'm going to start with Amir since he's my neighbor. And so Amir, you go ahead, please.
Thanks a lot, Leslie. And thank you so much, Leslie, for putting this together. I know that I'm really excited to be able to talk a little bit more. So this past year has just been a really interesting time, I think, for everyone. A couple of things that have been really important as we've gotten started with this has just been learning how to adapt with the pandemic. We'll talk a little bit about what the Respiratory Diagnostic Center and the university has looked like. But when we first started with the Respiratory Diagnostic Center, I was basically working there and trying to figure out what my role was. I'm a family medicine physician by training. I do outpatient, inpatient medicine, had really no formal introduction to infectious disease other than taking care of my patients who had it, but always wanted to do more and try to help out more. And I had just taken on a role as the clinical contact center medical director right before the pandemic started. And so what changed during that time was pretty dramatic and pretty quick. I have a 2-year-old daughter now who's at home, and so you'll see her next in the slide. And that's actually us standing outside of the Respiratory Diagnostic Center the week before we opened and planning out what it would look like. And I thought, well, what better idea than to take a picture of Ruth being out there so that we could put this down on a piece of paper and have it for her. Little did I know that for what I thought would take a couple of months, ended up being over a year's worth of work that's been in COVID. For the first couple of months, I, like many healthcare workers, wasn't sure what this would look like in terms of being able to transmit risk to my family. So Ruth and I didn't get a chance to hold each other for the first couple of months. When I was with my wife, she would stay upstairs, I would stay downstairs in our home, and we would just kind of sit outside in our front yard and distance, and that's the way we would interact. Of course, as we've learned more and more about this, we've gotten much closer in understanding what it is in terms of conferring risk. But I think over the past year, I've gained a great appreciation for what it means to be a healthcare provider. I've never felt that my work has been more meaningful, and I've gotten to meet some really amazing people along the way. 2 who are on here right now that we'll get a chance to talk to more. So there's very few things that I do now that I don't do with Amy. So I think it's only fitting that she kind of give you her update after myself, and we can talk a little bit more about what we've done together.
Thanks, Amir. So yeah, thanks for having me on this panel. It's an honor just to, a lot of work that I've done in the past that Dirk knows about, but like Amir said, we're almost attached at the hip at the work that we do now. But for me personally, I was already doing infectious disease research. So this wasn't something outside my skill set, really. So if you look at some of the photos and some of the things I was doing, which included, preventing mother to child transmission with HIV, working on TB, again, with the goal of helping pregnant women with other infectious diseases, and then doing a lot of work with David Wall and Billy Fisher to actually stand up and start Ebola testing and working in Liberia during their infectious disease outbreak. So that was a big thing. And so basically what I did was just draw on things that I already knew. So spending a lot of time in infectious disease was something I already loved and was doing before it became something I did in Chapel Hill. So on the next slide is basically where I met Amir before we sort of started really working together. So the big thing with COVID was that we didn't really have places to do infectious disease research with this particular pathogen. And so setting up various clinics so that we could have a safe place for our patients, but also a safe place and a welcoming place for the staff and for our own selves to be able to work in various ways to work through treatments, novel treatments that weren't being used or were being used in different ways. And then also working through vaccine, and a new network that came out for infectious disease research so that we could also do some of this work with our global partners that we're linked with, that I'm linked with infectious diseases. So not just in North Carolina, but also Malawi. And so for me, it was a little bit of like being in Chapel Hill a lot was odd because I had been just all over the world for the last probably 14 years. And then being able to draw on things that I had learned from being a global infectious disease researcher and then sort of implementing them here in Chapel Hill was a sort of a backwards transition, if you will, but it was a really exciting time because I knew I could help. So when this all started, I knew, I contacted Dirk, I contacted, my own bosses here, Joe Eron and others, and said, what can I do? Because this is what I know how to do. And then, of course, the lab and the testing came up, and another place where we turned something into nothing. And we'll talk a little bit more about how exciting it has been and how challenging it has been, but it's been a really difficult time to work here, but it's been an amazing time and we've done a lot of amazing things.
Okay. Can everyone hear me?
You're good.
We're good.
Yeah, so I had to adjust the microphone a little bit. I have known Amy for like 10 years, and I would run into her either in Cape Town or South Africa or Nairobi on our ways to various spots where she would set up infectious disease laboratories, and I would go in and establish cancer diagnostics, preliminary or primarily in Malawi, of course. And I never met Amir. To this day, I have never shook Amir's hand, which is bizarre. And it just reflects on how we all adapted to working through Zoom and remotely. Not many of you will remember, but I was on here back last year when we started sequencing the first variants in the state of North Carolina, because we knew back then that in addition to testing, we really needed to have a good understanding of the epidemic. And back then we thought, well, we'll do this for a year and then it's another 3 years before they have a vaccine. And so I'm blown away of how fast we had a vaccine. And so the work then that I'm doing hasn't changed much. We're moving away from testing to more sequencing. My son is still at home. He's 14 years old, Christopher. At first I thought, hey, this is great. I can teach him math every day. That turned out not to be a really good idea. So he learns the math by himself now. And I always used to take lots of photography and all over the place. But what I realized is you can take just as exciting photography really close to home and look very closely of what's happening in North Carolina, particularly now that the spring is coming. So we're adopting, and the world is even close by, just as big as it is when I used to travel. And with that, that's sort of all my personal life right there. Leslie, do you want to?
Sure, go ahead. We're going to pull up your slides here.
Yeah. So I have just a few slides just to perhaps set the stage. This is actually my laboratory, and it's the way that Amy set it up, because she walked in and said, like, I have nothing to do. And I said, can you set up our sequencing lab? And what you can see and is on the left, there is a hood where we have the yellow square, and on the right, you have the red one. And that's to differentiate with being positives and negatives, samples that we know that are positive and samples that we want to diagnose. And so the question that was in the chat is false positive, false negatives. I think we're getting better and better at differentiating, and it becomes more important now than before. If you look closely towards the right, it says Zika virus in this hood, because the UNC Viral Genomics Core has been in existence for about 10 years. And when we specialize on outbreak viruses and cancer viruses, and actually one of the last places that I met Amy was in Zika forest in Uganda, where I looking through to see if there were new viruses. And all of that came together in a pinch now to work on SARS-CoV-2. So I'm going to give you an update on what we've been doing and particularly focus on sequencing and variants. So the next slide, please. This is from about a month ago. This is Linda Pluter, a technician in my lab, and she's operating one of our sequencing robots. And the capacity that she has is 16 genomes per person, that's Linda, per robot every 28 hours. So we put the sample in, 28 hours later, we have the sequence. Now you can debate, is that a lot? Is that a little? Is that what we need for surveillance? But I think one way to look at it is if someone gets admitted to UNC hospital today, 24 hours later, we know which strain that person has. And I think that's really a benefit that we already do this for cancer genomes, where a lot of the treatment is targeted. And we have now that same capability research-wise for SARS-CoV-2. And if I can have the next slide, this will actually go very fast. This is what I talked about last time, which is our work back in June, July, where we identified the first cases that were introduced into the state of North Carolina. And what you can see, there are two arrows. The one that's up from the left comes from Seattle. That's a person who visited their relatives in a nursing home in Kings County, Seattle. And the other one that says Europe is a group of 3 individuals who came back from a river tour from Italy at about like 4 days apart, really. And they brought what is called the first variant to the state, the G614 variant. And the way it works is they're all spike proteins. So it's one part of the virus. The amino acid number is called 614. And the variant changed from a D to a G, which are different amino acids. And ever since then, we've been sequencing, and ever since then, the virus has spread within the state. And if you look at the bottom, there are a couple of names that you probably remember. There's Ralph Barrick, who is the only one really who can grow the virus in culture, and the only one who can tell us what are the biological phenotype of a new virus. Blossom Damania is our Vice Dean for Research, and Melissa Miller, you've had on earlier, is the head of the McLendon Clinical Laboratories, which does all the testing for the Respiratory Diagnostic Center and the hospital. And basically every sample that Melissa tests at McLendon Lab, sooner or later ends up in my lab for sequencing if it's positive. Going to the next slide. These are all the sequences of SARS-CoV-2 for the state of North Carolina, not just in February 2021, but for the entire year of 2020. So for all of last year, what we had were a total of 750 complete genome sequences. The little things that are in blue, and it's a circular tree, the little things are in blue are the sequences that were provided by UNC Chapel Hill. UNC has provided half of all North Carolina genome sequences up to this day. Every little one of these blue dots means there is a sample that originated with Melissa Miller in McLendon Lab, made it over to Linda. Linda puts it in the sequencer. 28 hours later, it comes to my desk, and then it gets submitted to GIS8, which is the international database where all the sequences are collected. So I think it's a great success, but there's another way to look at it. If you know, and you all know that, how many people are infected in the state of North Carolina. For last year, we haven't even sequenced everyone who has died. And I think that's what you read in the newspaper about our lack of capacity. Let me go to the next slide. This is fast forward. This is from the week of February 18. And I'm going to share with you the raw data because I think it helps us to gauge what you read in the newspaper. If you look at this, what you see is there are blue arrows on top. These are the proteins of the virus. Then there are rows. Each of these rows is a sample, and they're color coded. Some are red, some are blue. They're simply ordered by how similar they are. And then the black marks in the middle are mutations. And so what we call a variant, meaning is just all the red guys that are similar to each other, and there are more than 5 of the same. That's the variant, period. And the other thing that you can see is there's a lot of black marks on this slide, meaning this virus does mutate really quickly, and it mutates all the time. This is within 1 week. Let me zoom into the spike, which is the second to last slide here. This is now looking at the protein that is the target of the vaccines, of every single one of the vaccines, and it's the one that's required to enter the cells. And again, the rows are the samples for 1 week, and the black marks are the mutations. And what you can see is there are a fair number of them, and usually each row has like 1 black mark. But if you look where the red arrow is, you can count from left to right, there are about 7 black marks in a row. So this variant has 7 mutations, and that's the B117 mutant, which we identified the first week of February at UNC Chapel Hill. And it's a concern because there's so many at the same time. In fact, our immune system is really good at recognizing a wide variety of mutants, but 7 at a time, that's cause for concern. And then the last slide, if I could have that, these are some of the questions you had submitted earlier. I went in and looked this morning to update those. As of February 1 to 28, the month of February, the entire US has deposited 22,000 sequences, or about 1,000 new sequences a day. This is not North Carolina, this is the entire United States. During the same period, not the same period, but on one day, March 1, we had 49,000 cases. So it's about 1 in 100 cases that get sequenced. And I do expect that to go up dramatically. I'm a little concerned that with widespread sequencing, there is actually no clinical information. And so at the end of the day, if we wanted to change clinical practice, it is better to have that information locally. And that's what the rapid turnaround sequencing that we're attempting is going to do. It's really hard to predict what these mutations do. And that's the part that doesn't scale. I mean, at the end of the day, it's going to be Ralph Barrick's people infecting tissue culture cells to tell you what the variants do. Regardless, though, viruses follow the laws of physics. So if the virus cannot enter your nose because there is a mask, it doesn't matter which variant it is, you will not get infected. We do know that 2 of the monoclonal antibodies that are used as treatments no longer work against the variant in South Africa. Others still do. And I think that's pretty much a race between the people that develop therapeutic antibodies and the virus. We know that a lot of the small molecules, and Amir can talk more about that, still work because they don't have anything to do with the spike proteins. And I just had my lab check, but as of today, all the vaccines work against all the current variants. They were made against an old strain, but they still work. And so I think if we can suppress the virus enough before the fall and can attain herd immunity, then we will have at most 1 booster shot, but we will not have to have shots every year. If we cannot get this by fall, I think we'll have a repeat of 2020. And with that, I'm gonna hand it over to Amir, and please put questions in the chat so we can answer them afterwards. Thank you very much.
Thanks, Dirk. And so I think one of the things that was important that Dirk outlined is kind of the way that the samples come to him to be able to do this work. One of the things that's been really exciting about all of this is the way that we've tried to coordinate our efforts. So I'm going to walk through with Amy just a little bit about the respiratory diagnostic centers that were set up and established, where I showed you that picture at the very beginning. And then we're going to shift frames into talking about what we've been doing over the past few months in terms of trying to get more understanding of community variants, especially in a university setting, and testing in a university setting. So that picture that was there at the very beginning, you saw is just a bunch of trailers and a parking lot. That's what we had whenever we first started thinking, how do we do pandemic management? We went to different areas on campus and thought, honestly, one of the questions that we thought was, how do you think that the parking is going to be there, or help us out with parking for a couple months? Because how are we going to make sure that people still have their parking spots available in a few months? Little did we know that we would be doing a lot of virtual world, I guess, from there going forward for the past year. So the respiratory diagnostic centers gave us an opportunity to establish, one, safe and efficient testing, but two, an ability to try to respond to ongoing cases that we could see. So David Wall, myself, and a team of other people started trying to figure out where that would be, what that would look like. And it was the day before we decided to open the Respiratory Diagnostic Center that we shifted from this idea where he brought in a lot of his expertise from what they had done with Ebola, and then also treatments across the world, where I was at the time wasn't sure what clinically we would see that was significant. And so thought, does everyone need an exam? And if it does, we need to do a unilateral flow in and out, and make sure there's no areas where people can come and go to infect each other. We went from that being our primary standpoint to saying, gosh, what if we had to test 100 people in a day? At that time, 100 seemed like a lot. We can't really do that effectively in a trailer model. So the day before, we decided, you know what, we're going to do this drive-through model that we've been seeing and reading about in South Korea. And that's what you guys may have seen set up through the respiratory diagnostic centers. So we started with a capacity to do, about 100 tests a day, working very much close in hand to hand with Melissa Miller in trying to accommodate what she could put through in her lab. Then 100 became 200, 200 became 300. At our peak, we were seeing around 550 people come through in a day. As Dirk had alluded to, that was the primary standpoint of the samples that had been coming through that would then get sent to Melissa's lab. If positive, they would end up with Dirk so that he could sequence them. In addition to that, what we did is that we quickly allowed a safe way for our clinics to continue to see patients that weren't COVID-related risks. And then this is where my relationship with Amy really started, was thinking, okay, if we're going to have an area where people come out, how do we do this in an effective way? And I think part of what would be neat is hearing from Amy about how they did their clinical trials at the RDC. And then we're going to pivot to talking about how that relationship from us started in what we're doing with the university in more of a confined community setting. So I'm going to turn it over to Amy to talk a little bit about what she was doing at the RDC while we were doing all the swabbing.
Yeah, thanks, Amir. For us, it was, how do we do what we do best? And that's infectious disease research. How do we get these novel therapies with, Ralph Barrick and Billy Fisher and, a lot of my colleagues and friends, and actually have a space to do this, because it's not just getting that swab when you're doing infectious disease research. So one of the very first moments of meeting Amir was me running around the RDC saying, I need to collect blood. Like, I need to do phlebotomy on COVID positive patients, not like people just coming with symptoms and getting tested and moving, but like, I need them to be comfortable. I need us to feel comfortable doing it. Like, what do you have down here? What can I do? And sort of like finding other friends and colleagues on campus to give me, some things that we could turn into an actual clinic. And Amir, as everyone who knows Amir, was like, yeah, we can do that. Let's just go see what we have. And so we found phlebotomy chairs. I built, we took the small tent and we made rooms that would flow, that would allow, the patient to feel comfortable, to come out of their car, sit, give them a welcome packet and say, yeah, this is not fun right now, but you know what, we're going to learn something from this. And you're doing, like, the one thing that anyone could do is learn from it. And so a lot of, at first with observation studies, just sort of following the disease. And then it became treatments, and then it became okay, well, we have treatment clinics and, you know, we've outgrown this space. And so then it was me sort of trying to make a clinic out of, you know, various things that David would find, you know, a kidney truck, and then being able to make someone feel comfortable, you know, boarding a kidney, you know, dialysis truck to then do their COVID trial, you know, bringing their child or whoever, you know, and all of us sort of like working through that. And so just really, then we got, you know, into the heat of North Carolina, and another time when my work in Africa comes in handy. I know what it's like to be overwhelmingly hot in PPE. And so then trying to figure out, like, how do you turn on a fan? Like, what should we do? What makes this, you know, infection prevention work, as well as doing the work that needs to be done safely. And then David and Billy worked with others with UNC Health and got us a couple rooms in the med school skills lab. And if anyone's been up on the 3rd floor of the ACC, you will see that I turned that into a treatment clinic for actual infusion. You know, these monoclonal antibodies that we're talking about, we have an infusion center that we're actually able to make, again, the patient feel comfortable and us all work in a safe place that we know is going to keep other patients in the ACC safe, as well as ourselves and our own patients. And so just building these things whenever you hit the challenge and then just walking through it, it was great because I got to, you know, work with people who were already here or, you know, had done some other work, but turning any space, you know, there was a moment which everyone laughs at me, but I had sort of a sidewalk clinic at one point just to be like, well, you know, we can't really go into the truck or go onto the van, but, you know, you can still participate in research and we can, you know, go through your clinic visit here. So we've got an amazing research team, infectious disease, you know, group here that I get to work with all the time. And so helping them see something, a friend and one of our research nurses just was like, listen, Amy didn't get Ebola, so let's just do what she says. So we just sort of adapt to, you know, this isn't Ebola, and she didn't get that. So we're pretty sure like we can just sort of make sure that we're doing the right and safe thing. So just doing a lot of like donning and doffing of PPE and teaching people really to feel comfortable just within the confines of doing research in an unsteady and unstable setting pretty much every day. But having the RDCs where they were and incredibly close to infectious disease anyway made it really easy for us to take on something a little more meaningful for us. So like diagnostics was a big thing that sort of got sorted with Melissa Miller and Amir and David and stuff. But then our group doing what we do, I got to sort of do my little niche and build things that didn't exist in parking lots, which I do well.
So I think one of the things that Amy brought up was really important is that, so when we started kind of developing throughout the RDC, we got through about in our first year, over about 80,000 tests that were performed at the RDC at the ACC. And that was for UNC Health, the largest center that provided testing for the community. So a really big impact in the community. You can tell from Amy's infectious ability to say, let's do this, why we partnered really well with each other. So we're going to fast forward a little bit to October. At that time, the university was considering reopening and trying to figure out what it would look like if you brought more students onto a college campus. And there were a lot of college universities around the country who had started doing their own testing programs. And the question was posed, well, can we do this? You have to remember, Amy is the lab genius behind the brains of all of this. She's set up PCR laboratories all across the world. I'm a family medicine doc that really had never once stepped foot into a lab, but I had a partner who was willing to listen to my crazy ideas, and then also someone who was willing to say, you know what, we can do this together. So as we started progressing through, it was this question in October, can we set this up? Quickly became, yes, we can set it up. And we said, okay, great. January 11th, we need to have a lab that's up and running. And when I say we need to have a lab that's up and running, we literally had no space identified at the very beginning when we were working through the process. We had to make decisions about where things would go, what the equipment would look like, and let alone doing things like get staffing, supplies, et cetera. So Amy and I spent the first few months there, and from October going forward, trying to figure out how we could do testing on a large scale. And Melissa Miller was very helpful in saying, you know, one of the things that would be helpful is if you could find an automated process to drive you through this, you cut down on the force of the number of people that you need, but also would make sure that you don't have repetitive injuries from the quantity that you would have to test to keep a university setting safe. So we did some back of the envelope numbers, number of students that were living in the dorms, number of students living in the community, and what it would look like to keep that safe. And we were shooting for around 13 to 15,000 tests a week. That's a lot of tests a week. Remember, at the ACC RDC, we did about 80,000 over a year. So we were thinking we would hit that really, really quickly. So we got together with one of our vendors and we ended up purchasing what's called a Thermo Fisher Amplitude, which can have the capacity to do up to around 6,000 tests per day. But as Amy had mentioned, we were still in this time, October, January, where we were seeing kind of a rise in case numbers. So we weren't really sure what that would mean for our supply chain. Fortunately, we were able to secure everything on the supply chain. We would call each other and say, okay, like, I got the swab guy, you know, like we've got the swabs, we're good there, you know, let's get the tubes, we've got the tubes now. And so what started off as these 1, 2, 3, 4, 5 boxes that we were checking through ended up becoming a lab at the Genome Sciences building, which is quite state of the art, where we're now doing about 14,000 tests per day. Actually, yesterday was a pretty big highlight. We started January 11th. We processed our 100,000th sample yesterday. We were very, very proud of that. Amy's team has been working around the clock diligently to make sure that that happens in a safe and effective manner. But the other thing that I think both of us would be really proud of is that our prevalence rate among the community that we're serving, which is the university community and the Chapel Hill community at large, has been extremely well received. So we've, out of those 100,000 tests, our positivity rate is around 0.4%. Over the last week, it was at 0.12%. So that means for all the samples that we get, 0.12% are positive. This has allowed us to keep not only the university safe, open, but to also keep our community safe as well. And that's been really important in this process. Amy, do you want to tell them a little bit about like what the life of the sample is and how you go through that process? So that I think one of the things that was amazing for me to see, I knew what happened from someone getting a sample and then getting their test result. That whole middle was a big black box. And this is what Amy does all so well. So she'll guide you through that, and then we'll wrap up about kind of what that's looked like. And I should have mentioned one of the things that was key, Amy and Susan Fiskus, this is a CLIA certified lab. So we are able to report our results just like McClendon Lab would. We set up a CLIA certified lab in the past 2 months. So it was a huge undertaking, but one that was really awesome to do together.
Yeah, so we'd be really remiss to not mention Susan Fiskus, sort of the linchpin for me being involved. Simply, she said she wouldn't do it without me. And so called me and said, can you do this? You know, and of course I'm like, yeah, we can do it. We'll figure it out. Like, it's an aggressive timeline, but you know, we'll see how it goes. And so without her steady hand and guidance throughout my entire career, even as a retired person, she and I would still meet. We'd talk about, you know, what I was doing for Ebola or TB or whatever it was. And she would certainly have an opinion and help me figure it out. So without her as part of this whole process, we would still not be nearly where we are now. And so, yeah, so the goal being that it needed to be a CLIA lab, and that we, you know, took on, you know, the CAP program, and we participate in the proficiency testing program, and we've successfully, you know, passed all 3 that we've participated in so far. So that's a big milestone for us, a brand new lab, really doing what needs to be done as an established lab would do. The samples themselves, it's a really important part of what we did was to make the automation simpler for our staff, because it is still humans that have to do a lot of this work. A lot of folks who visited the lab say, oh, well, what robot takes off the lid? What robot removes the swabs? And I'm like, well, those are the human robots. We're doing that part, you know. So like the specimens, We've done our best to keep the specimen integrity in place. And so anytime you're working with viral transport media, that means cold chain and making sure that the swab, the tube, that things are happy. And then it arrives here at our laboratory from these various coolers. And we scan it into our LIS system, which is completely connected to our amplitude system. So at the end, we have a final result from this one barcode. We prep those kits in advance. We have so many student volunteers here. So the undergraduate student volunteers at Carolina are building these test kits for themselves, right? So it's really remarkable work that we've all bought into, a community, protecting a community. And so then the sample themselves, they come in, we do actually heat and activate them. So we worked with Ralph Barrick. I had worked with him on one of our research studies. So I knew what they were doing to inactivate specimens. So I was like, why reinvent that wheel? And worked with their team there, got our samples into a place where we can heat and activate them. So much like what Dirk showed you earlier, we've got color-coded labs. So we know when we're working in live virus part of our lab, and then when we're working in an activated virus part of our lab, so that flow is very clear and it's easy to see. And then we can just simply move through our color-coded section into what happens next is we have a giant, what I call a TCAN on steroids. A lot of folks around campus probably know what those are, but it really just preps the sample for the extraction. It's huge. It does all 376 at a time. It's really amazing to see. Like, I've done a lot of PCR in my life, but I could not do that many at once. And so it preps those plates, and then those plates go through the actual robotic system, which is really quite impressive to see. I do recommend checking it out sometime. I know we don't have time to take a tour of the lab, but once it goes on there, it does do a magnetic bead extraction. We have got 4 of those working at one time. So each 96 well plate goes through an actual RNA extraction on this module. Gets cleaned, gets washed, through PCR as typically done. And then a PCR plate of all, 384 at once. So it's this big compression plate that this other TCAN robot sort of brings into one. So it brings all 4. And then within an hour and 15 minutes of that, you have 384 results. So the process is fast, it's efficient, but as I said, do not diminish the robotic humans that are actually unpacking these samples, prepping them and activating them, pulling the swabs, removing caps and then placing caps back, new caps on. So there's a lot of dedicated humans that really complement these robots, and so it's a fun place to work. I think everyone really enjoys like when the robots, are doing their thing, but also just a very busy human level way to get around our systems. And but the life of the specimen here is fascinating. We are archiving our positive specimens. We are working on sequencing, the student, faculty, staff, our population in general, so that we'll know a little bit more about our variants as well. And that work is just getting started. So I don't really have a lot to report yet, but I can say that we, are working towards having sort of multiple goals, not just diagnostics of, asymptomatic folks.
So Amy and Amir, it's pretty amazing standing back and watching, knowing where you were 3 months ago without a lab, without any equipment, and to do that many thousands of tests a day. For those of you not involved in setting up a laboratory or kind of understand the process, amazing is an understatement when I say it. I can't say enough adjectives to tell you what they've done. There's a couple of questions around the testing. Some of the people have seen the data from UNC Chapel Hill, the number of positive ones, others haven't. So maybe a comment about the percentage of students that are positive, faculty, staff, and then it's probably a little bit different than you anticipated. And why is it different?
I apologize. I'm going to mute for just 1 second.
So right now, the PCR testing, very few are positive in student and staff. And we had, in fact, ran a trial on the staff as well. It's not because they're already infected and have antibodies. That's not true. A lot of our students and a lot of the community has not encountered COVID. The natural infection is around 5 to 10%. So 90% are naive. And I think the operational restrictions that are put in place at UNC, the dorms, the way the classes are conducted, maybe the students are really scared too from the fall. One would hope they learn. Those are the reasons I think that we're not seeing more PCR positives. And I'm going to see if Amir has time to add.
Thanks, Dirk. Yeah, I apologize. I'm in the hospital, so I apologize for that overhead page. But yes, I totally agree. So one of the things that we wanted to make sure was that we didn't cloud this data and this information. So anybody who would like to, if you just type in UNC COVID-19 dashboard, it will take you to that dashboard that is updated daily. Every day at 4 o'clock, the data from the day before gets put in. What you'll see there, one of the things that we wanted to do is we actually exclude people for a period of 90 days that have been tested prior positive. So these aren't people who have priorly had a positive test that are testing positive again. We try to follow the same guidance that the CDC has been having. But one of the things that I think has been very pivotal in this is the fact that we are doing frequent testing 2 times a week for those who are living in dorms or having in-person campus, 1 time a week for those who are off campus. We have a chance to really work fast in terms of identifying cases. So I'll just walk you through just a very practical example of this. Because we have our own lab that reports our own data that can then report to the state, we've actually bypassed a couple of steps. Normally you would have to report to the state that then comes back to the county. Because what we have is set up that we can also report to our campus health department. If I get a test result at 2 o'clock and I notice that there's an increase in cases, I can tell the campus health team, be on the lookout. We've had a small increase in cases that I'm seeing. I'm going to release the results. Please do the tracing. Our campus health team is doing that now on average. Within 4 hours, they're tracing people if the results come in during the day. This may have been a 2-day lag beforehand, maybe a 2 to 3 day lag beforehand, because the results were coming in through another entity. So that's been super helpful. As of right now, we are at 0.4% positive rate in the entire community with all the tests that we've done. So that's been really, really great. And that number has actually been 0.12 over the past week. We have seen a decrease in that number of positivity, likely due to our ability to quickly identify and do our case sourcing.
Okay, good. So there are several questions I'm going to try to group together to ask each of you together, several about boosters. And so there's a 2-shot routine for a couple of them, a 1-shot routine for the J&J. All 3 are 100% effective for preventing hospitalization, severe disease. But with the variants coming, there's talk about, will we need a booster? And if we will, when's that likely to be? So just your thoughts.
Yeah, I think to start out with that, what you said, Dr. Burks, is correct. All of these are 100% effective at preventing disease. And that's really the gold standard, right? Overall survival in a randomized trial. Everything beyond that, whether they're 80% or 40% or 95%, is as much guesswork as dependent on the assays. I think it would be helpful to have a booster shot, particularly if we can get and use some of the platforms that don't require refrigeration. When that will happen, I think depends a lot on when we can get everyone their first 2 shots. And then it really becomes a very complicated question to say, do we want to boost as early as possible based on the variants that are around, or do we want to make sure we get a complete picture of all the variants that are circulating globally and build the best vaccine possible? And those are really tough questions. So I don't think there is a clear-cut answer, but I'm hoping that if we can get the overall positivity rate down before fall, before the next semester and the next K1 to 12 semester starts, we will have the luxury to put together the best response possible. And that's just my personal impression.
Okay.
Dirk,
Amir, you want to add something?
Yeah, I totally agree. I mean, I think one of the things that's wonderful about being a family medicine physician is I get to work on both sides of the spectrum. So currently I'm calling you from being one of the hospitalists right now at Hillsborough. So I get to see what it is to see someone in the outpatient setting and then also in the acute inpatient setting. Number one goal in all of this is preventable disease from morbidity and mortality, which is what these vaccines do really, really, really well. So if we can keep people out of the hospital, that's the game changer right there. That's what we're all striving to do. And whether that's a one-time booster, like we sometimes do with the pneumonia vaccine, versus whether that's a yearly booster that we may do with the flu vaccine, I think that we still need some learning to do there, and that's where Dirk's work in variant study is going to be super helpful. But I am very, very hopeful that these preliminary studies and what we've seen in terms of being able to kind of curb the hospitalization rate, the mortality rate over the past little bit here will continue as a positive trend.
So Kurt alluded to it just a second ago, but Kurt, say it again. In North Carolina, the number of people that are antibody positive that, like in the studies that y'all are doing, what's the percentage right now?
The percentage right now of people who don't know they've ever been infected is below 10%.
Yeah.
So that these are individuals who had mild disease, or these are individuals who were infected any time between today and last January. So that's actually really, really good, because it means that our public health intervention in the state works. It unfortunately also means that we have to vaccinate 90% of the population in North Carolina in order to get everyone.
Right.
But I take that option every time over people getting infected.
Right. So the percentage of people that are antibody positive are lower than maybe people would have thought, but in a good way. The percentage of people in North Carolina that have had at least the beginning of the vaccination process is in the 17, 18%. So you can put those two numbers together to think about where we are. There are several questions about herd immunity, and herd immunity is a pretty broad number. People have talked about 65%, others talk about 85, 90%. When they do something like that, you can hear that nobody really knows. But it's certainly a race between the people getting the vaccine and the variant spreading and who gets there first. So Amy, Amir, other thoughts about herd immunity?
Yeah, I agree with you. That number is, take a dart and throw it on a board and put the 65 to 85, and that is the answer you'll get, right? And so the goal will be as many people as possible to get that trend for new infections down. And so we've seen this before with other viruses and other diseases. It's a little bit more clear cut in some other things, such as polio, where you can hit herd immunity status. But definitely in terms of a virus, it's trying to think about how fast we can be adaptive to getting the vaccines out, which I think we're trying to do as fast and as efficiently as possible, versus how fast the variants go. And I'd be interested in Amy's work with infectious disease, if she has anything additional to add.
Yeah, it's very funny to bring this up, because even Amir and I were talking yesterday, what type of testing does one need if we do get to this herd immunity, and what is that percentage, and what does it really mean? And I think it's really still the throw of the dart. Like, is it 65? Is it 85? What are we going to do? But, and I don't have a better answer other than that's, herd immunity is going to help, but variant persistence is also going to be part of our ongoing game to beat it.
So we have about a minute left, and I want to ask one question, just your thoughts quickly. Yesterday, the CDC came out with new guidance about those that have had their either both shots a couple of weeks later or their J&J a couple of weeks later, about being indoors with others that have been immunized and taken their mask off. So what's your comfort level with that?
I personally still, I feel like I feel very comfortable in my mask right now. And I think I'm going to continue to feel comfortable in my mask unless it's very, very close family and that we're seeing. But I'm not going to, one of my favorite things to do in the fall is go to a UNC football game. I'm not sure I'm going to do that right now, but I hope that one day we'll be back there.
So now, Amir, Amy, Kurt, you're in, Amir, you're coming next door to my house. You're visiting with your family. They're all, pretend they've all been vaccinated. You and your wife been vaccinated. You gonna take your mask off?
Yeah, I think in that setting, I feel comfortable.
Okay.
One of my favorite things to do is to give a big hug to my nieces and nephews. I haven't really done that, quite honestly. And so that's one thing that I'm looking forward to doing.
Good. Okay. Well, Leslie, we'll turn it back over to you. I want to thank Amir and Amy and Dirk. It's the work you're doing is amazing, and I appreciate you being on with us today just to talk more about it.
Sure. Thank you so much, Wesley. I appreciate it. And thanks to everyone for joining us again for this session of Game Changers. As we close out our time together, I just want to share, of course, our resource for anything COVID related, the UNC Healthcare link here. And if you are interested in supporting the work that you've heard about today, I hope you'll consider doing so through our COVID-19 Response Fund. Dirk Dittmer, who was on the call with us today, was supported through this fund. So some of the work that he's doing has directly benefited from philanthropy that you all have given. So I want to make mention of that as well. Second, I'll just say that our next session will be on 2 weeks from today, Tuesday, March the 23rd, and we will welcome a discussion on health equity around the vaccine distribution. So mark your calendars for that. Invitations will be going out soon. And then lastly, I'll just say, once you log off of the call today, there will be a survey. So I'll just ask you to take a couple of minutes to take the survey so we know what we're doing well, what you'd like to hear more of in future sessions, and go from there. So again, thank you so much for joining us. Have a great afternoon.